Thank you, Dr. Parikh. Thank you for the invitation and it's an honor to be here and present. I'll be talking today, shifting gears from colon cancer and talking about upper GI malignancies here and discussing a hotly debated area on perioperative approaches in patients with esophageal and gastroesophageal junction adenocarcinoma. So we'll be covering the evolving studies that led to how we practice today and trying to address the question of those patients who are complete responders versus partial or non-responders in esophageal cancer and whether adjuvant therapy is worth it or not in each scenario. Those are my disclosures. So we'll cover the landmark studies that led to how we practice and how are we now debating those approaches. So when we talk about neo-adjuvant chemoradiation in patients with esophageal adenocarcinoma or squamous cell carcinoma, as well as gastroesophageal junction adenocarcinoma, we typically refer to the CROSS regimen. And that is based on the CROSS study that compared neo-adjuvant chemoradiation with carbotaxol followed by surgery versus surgery alone. This trial enrolled around 360 patients with esophageal or gastroesophageal junction cancer. Most of the population of the study were adenocarcinoma, but it also was tailored to the squamous cell carcinoma group. If you look at the outcome with this regimen in this population, there is better pathologic responses with more enhanced pathologic complete response, 49% in the squamous group as opposed to 23% in the adenocarcinoma group. The R0 resection was also higher in the squamous population than in the adenocarcinoma population, which is kind of expected because the squamous population respond better to chemoradiation than adenocarcinoma. So looking at the long-term follow-up from this CROSS study, the 10-year overall survival data. And if we're going to look at separating this by histology, those patients with adenocarcinoma at the 10-year mark, so the 10-year overall survival was 36% in this subgroup as opposed to 26% in those who had surgery alone. In the squamous population, the 10-year overall survival was also enhanced compared to the surgery alone. But just looking at the adenocarcinoma here, the 10-year survival was 36%. Looking at the patterns of failure on this study, as you see, the patients who received chemoradiation as opposed to surgery has way better local regional relapse rate, much lower peritoneal carcinomatosis, and hematogenous spread. Shifting to talking about perioperative chemotherapy, what if we drop the radiation and just look at perioperative chemo approaches? So the landmark study that preceded the FLOT regimen in this population is the MAGIC trial, the European MAGIC trial that tested the ECF regimen. So ECF has been there for a long time until the FLOT4 trial was presented and replaced ECF. So the MAGIC trial looked at ECF for a few cycles, then surgery, then ECF for a few cycles. We call it perioperative chemotherapy approach. Sorry, there you go. So with the FLOT4 trial, which is the landmark trial that led to why we use FLOT now as perioperative approaches, in this study, 716 patients were enrolled, and mostly gastroesophageal junction adenocarcinoma and gastric adenocarcinoma. There is no esophageal or esophageal squamous population. And if you look at the 5-year overall survival, we're talking about 45%. So FLOT was superior to the MAGIC regimen, 45% versus 36%. And that is why we favor FLOT if we're going to choose a perioperative approach with a patient that could tolerate FLOT. Because a FLOT has some limitations because of its toxicity, so not every patient can tolerate the additional chemotoxicity. Looking at cross-comparison across those two studies, FLOT4 versus CROSS regimen, you see here the 5-year overall survival with FLOT is 45%. And just looking at the adenocarcinoma population of CROSS, the 5-year overall survival was 43%. So kind of similar if we're going to look just at the adenocarcinoma population, knowing and considering that the population of CROSS are mostly esophageal and gastroesophageal junction adenocarcinoma, while in MAGIC, we're talking about gastric and gastroesophageal junction adenocarcinoma. And both of those populations have their own cancer biology and their kind of different prognostic outcomes. And so, yes, kind of similar, but we're not comparing apples to apples. And this is what I'm talking about here, that a study that primarily looked at gastric versus a study that primarily looked at esophageal, but has some gastroesophageal junction in it, and how the cross comparison can lead to some biases. So most recently, or one of the recent studies that kind of addressed the debate whether to use cross, like chemoradiation approach versus peri-op chemo approach in this population, is the neo-adjuvant study, which came to address the question of which one. So compared head-to-head the MAGIC approach versus the cross approach. The MAGIC approach, or the MAGIC arm, offered investigator choice chemotherapy of either the MAGIC, ECF, or FLOT. So it was not restricted to just FLOT, that arm. And then the other arm is the typical classic cross regimen of carbotaxol and radiation. So the study compared both, and around 377 patients were enrolled, and it's primarily tailored to esophageal and gastroesophageal junction, so no gastric cancer. So 100% adeno here. And if we're going to look at the pathologic responses, comparing cross versus the peri-op approach head-to-head here, you see there's better pathologic responses with the cross regimen. 16% versus 5% pathologic complete response rate. And then similarly, the R0 resections and the lymph node negativity is better with cross than peri-op chemo. However, when they looked at survival, the study was built with a non-inferiority design. And as you see here, the hazard ratio was 1. There was no much difference on 3-year survival between whether you use cross or peri-op approach. One thing to keep in mind here is that because the chemo arm was not that clean, because some of the patients received ECF, others received FLOT. So it brought up the question of, can we take this data and conclude that those are non-inferior or not? The conclusion is suggesting that chemotherapy is not inferior than the cross regimen, but we need better confirmation with a future study. So there's currently an ongoing study called ESOPEC, purely comparing the FLOT regimen versus cross in this population, esophageal cancer and gastroesophageal junction adenocarcinoma. Other noteworthy ongoing peri-op chemoradiation trials in this space is also the Top Gear study, which is looking at the MAGIC approach and with chemotherapy, and then addressing the question, if we add a short course radiation, just like the rectal studies, if we add a short course radiation after induction chemo, will we capitalize on the FLOT regimen? So it is actually on the ECF regimen, the MAGIC regimen. So it's ECF followed by radiation versus no radiation. Those are two noteworthy ongoing studies that will help us figure out which way is better. So what should we do for patients who did not achieve pathologic complete response following neoadjuvant therapy? As you've seen from the studies I've presented, there is no clear guidance or questions on if those patients do not receive do not achieve a pathologic complete response, which is a surrogate marker for overall survival in this population. What do we do next in terms of chemo? Do we switch chemo to a different regimen or continue the same chemo for a few cycles to address the residual disease? There's no clear data from the studies to address this chemo question. However, there is a CALGB study that I would like to highlight. This is not in the adjuvant setting, but in the neoadjuvant setting, and they used a PET scan directed chemotherapy approach, where those patients, so the study addressed the population with T3, 4, or nodal positive esophageal or gastroesophageal junction adenocarcinoma. They have a baseline PET scan, and then they were randomized to 2 different induction chemotherapy, either FOLFOX or carbotaxol. And then at some point in the interim, at day 36 to 42, they get a PET scan. And then if they are responders, they continue with the same chemo concurrently with radiation. If they are not PET responders, they switch chemotherapy to the other. So if they start with FOLFOX and they're not responders, they switch to carbotaxol, and the reverse is true. And then they undergo surgery. So the goal of the study, or the rationale, is if those patients are resistant to this chemo, if we switch to a different chemo, will we improve or enhance the pathologic complete response rate? We know from prior studies that those patients who are not responders, their pathologic complete response rate is typically not more than 5%. So the goal by the switch chemotherapy approach here is to enhance the 5% rate to 20% pathologic complete response rate. So if you look at what they achieved with this PET-directed chemotherapy approach, is that those patients who are PET non-responders, they achieved 18% or around 20%. Whether they start with FOLFOX and you switch to carbotaxol, or if you start with carbotaxol and you switch to FOLFOX, it led to inflation of the pathologic complete response rate to where we want, around 20%, which is similar or in parallel to those responders. They followed 5-year survival for those patients who followed this approach, the PET-directed chemo approach. And as you see, the non-responders who switched chemo had a 5-year survival, overall survival, similar or in parallel to the 5-year survival that we are quoting for the responders. So this is one approach that we could do. I always get PET scans, and I sometimes practice this in clinic, where if they are not responders, I switch the chemo. Most recently, we all know immunotherapy is invading every space and really markedly invading the upper GI space, including the peri-op setting. So what is the rationale of adding immunotherapy in a patient post-chemoradiation? There's multiple studies, not just in the upper GI population, but in other tumor types like non-small cell lung cancer, where post-chemoradiation, the radiation and the chemo can modulate the tumor microenvironment to make the tumor more responding to checkpoint inhibitors like PD-1 or PD-L1 inhibitors. And this is a study that was done by Dr. Kelly, who actually led the Checkmate 577 trial. This data showing how the tumor microenvironment could be modulated by upregulation of checkpoints post-chemoradiation in this disease population. So this is the design or the schema of the Checkmate 577, where those patients, 794 patients, one of the largest peri-op studies done so far, and tailored to patients with esophageal and gastroesophageal junction cancer with residual disease after neo-adjuvant chemoradiation. So most of the patients were adenocarcinoma, and 29% of them were squamous cell carcinoma patients. The primary endpoint was disease-free survival. So they either got adjuvant nivolumab or placebo. So looking at the primary endpoint, which is disease-free survival, if you see here, there is doubling of the disease-free survival with the adjuvant nivolumab as opposed to placebo, 10 months versus 22.4 months. Very impressive. And this doubling was seen at the 24 months and at the 32 months. They also looked at the distant metastasis-free survival, which is one of the markers that we look at when we assess perioperative approaches. And as you see here, there is also an advantage favoring nivolumab versus placebo, and that is significant, hazard ratio of 0.7. They also looked at something called PFS2, which is a survival measured from the time of randomization to the time of progression after the first subsequent systemic therapy, meaning patients who developed recurrence after adjuvant therapy, after adjuvant nivolumab or placebo, and then progress on the first systemic therapy, so that time period. And that PFS2 was also showing data favoring nivolumab versus placebo. Looking at histologic subtype, it's a very large study, so each group is like a trial on its own. Looking at the adenocarcinoma group versus the squamous cell carcinoma group, there is more advantage in terms of median disease-free survival seen in the squamous population as opposed to the adenocarcinoma population, which is expected and in line with what we've seen with this histology in the stage 4 clinical trials that used immunotherapy in this population, as well as other disease types like non-small cell lung cancer. This is the subgroup analysis of this study, and I'm not going to go through all the details, but just to highlight, for example, the tumor location esophagus versus gastroesophageal junction, you see that the esophageal population may have done better than gastroesophageal junction, but we need to keep in mind that esophageal lumps both squamous and adenocarcinoma, and the better survival we're seeing here might be driven by the squamous population. Another thing I would like to highlight is the PD-L1 CPS subgroup outcome. If you look at the PD-L1 CPS score, patients who have higher CPS scores, 5 and above, had a significant hazard ratio for benefit with nivolumab versus placebo, while those patients who have low PD-L1 CPS score has hazard ratios touching the boundary of significance, and questioning whether those patients benefit at all from nivolumab. And this is a debate that is very much in line with the debate we're doing in patients getting immunotherapy with chemo in the frontline setting based on Checkmate 694. In terms of safety, most of you, immunotherapy is invading every space, solid tumors and hematologic malignancies, so you know the toxicity profile of nivolumab. And this trial toxicity profile did not show anything, deviating from what we know of nivolumab. So what's next after Checkmate 577? Now, if we're going to talk about standard of care, those patients who have resection post chemo radiation and have nodal positive disease, based on this study, we do nivolumab. What else? So immunotherapy is trying to capitalize now on what we've seen with adjuvant nivolumab, addressing the question is what if we incorporate checkpoint inhibitors in the neoadjuvant setting along with neoadjuvant chemotherapy or along with neoadjuvant chemoradiation. So there's several trials right now ongoing addressing both of those approaches. And one of the recent studies that was presented at this main ASCO meeting is the Dante study, looking at addition of atezolizumab to FLOT versus FLOT. And it's from the German group, Dr. Albatron, who also led the FLOT 4 trial. It's an investigator-initiated study led by him, looking at comparing atezolizumab plus FLOT versus FLOT. And this is the data that was presented at ASCO was just for the phase 2 portion of the study. They did the phase 2 portion to justify moving with phase 3 with certain cutoffs they had in mind. So just looking at the safety profile of adding atezolizumab or adding checkpoint inhibitor to FLOT versus FLOT, there is some inflation if you look at grade 3 to 4 toxicities, slight inflation of those significant AEs with the addition of immunotherapy, but not more than what we know for the profile of PD-1, FOLFOX or FLOT. The margin-free resection was not much different between both. FLOT performed very well, as you see, based on those data. But what is significant is when we look at the pathologic regression rate, again, pathologic complete response is surrogate marker of overall survival. When we look at the overall population, there is a 10% improvement in pathologic regression rate in patients who received the atezo versus those who did not receive the atezo with FLOT. However, when they did the subgroup analysis for those patients with higher PD-L1 CPS score, you see there's a significant, more pronounced improvement in pathologic regression, reaching around 28%. So clearly benefiting the higher PD-L1 score population. So the takeaway points is that it's showing us that the safety profile is manageable, and the study justified moving with phase 3, which we are looking forward to the results of that. Other key ongoing immunotherapy trials in this space addressing the same questions, a noteworthy trial is the Keynote 585, which will likely be resulted sometime next year. And it's looking at similar approach to the Dante trial, but instead of atezolizumab, they're testing pembrolizumab. So it would be pembrolizumab with FLOT versus FLOT. And hopefully that will guide us in terms of whether immunotherapy is worth it in the neoadjuvant setting. Keynote 975 is another study, but tailored to those patients who have locally advanced unresectable disease. So adding pembrolizumab to definitive dose chemoradiation. And then there is a study in parallel to Keynote 585, exactly testing FLOT with PD-L1. Instead of Pembro, they're testing durvalumab. And then talking about the chemoradiation approaches, there's also the ECOG 2174 study that is combining cross with or without nivo, then surgery. And in the adjuvant setting, they added arms of comparing nivolumab alone versus nivo epi. So we will know if IO versus an IO alone is a better option in this population. So very important study that will help guide us with regard to best chemoradiation options for those patients. And we have to talk about MSI-high, just like the colon population here. So how about those patients? The ASCO GI, during ASCO GI, we were excited to see this, the results of the core study, which is a phase 2 study, French study that looked at dropping the chemo or a chemo-free approach with just pure immunotherapy for this population and combining nivolumab and ipilimumab and using it in the adjuvant setting as well. So they presented just the early data from the study, but it was very in line with what we know of how immunotherapy works in MSI-high, regardless of tumor type. The data from colon cancer, neo-adjuvant immunotherapy in colon cancer, the dostarlimab data, as well as the other studies, showed similar or comparable pathologic complete response rate, as you see here, 58.6% with IO in the neoadjuvant setting. And that tells us that we're heading toward dropping chemotherapy for this population, as multiple studies previously showed that those patients do not respond well to chemotherapy and may not need it. And immunotherapy might be enough, not just dropping the chemo, but maybe dropping surgery for some of them. So as you see, this is the overall survival and event-free survival, very impressive outcome. So the take-home points, whenever I see a patient in clinic, I look at those factors. So pathologic complete response rate, the end status, the R0 resection, those are the surrogate markers for survival in resectable early stage esophageal and gastroesophageal cancer. If your patient achieved those, then the patient is in good shape. You don't need much, additional stuff. The two approaches that we highlighted has ins and outs, pros and cons. So for the cross approach, which is a standard chemoradiation option, we know that there's a higher post-op morbidities. The pathologic complete response rate could be enhanced in the setting of cross regimen or the cross approach with the PET direction of either same chemo or switch chemo based on the CALGB data. And then we know that Checkmate 577 and the use of adjuvant immunotherapy that could double the disease-free survival with nivolumab versus placebo, and always questioning the potential lack of benefit in those patients with PD-L1 CPS score less than 5. So I typically get a PD-L1 CPS before I decide about nivo in the adjuvant setting, and I look at the nodal status. So if someone has a partial response with nodal negative disease, I do not do nivolumab because the subgroup analysis does not show additional benefit in that group of patients. For FLOT, we noticed the standard peri-op option. We know the chemotoxicities, which will limit the eligible patient pool. So if you have a patient who's not a candidate for FLOT, based on the data that I presented, it's probably not inferior to cross, so you could do cross in those patients. There are ongoing studies post the Dante approach, which will possibly boost the pathologic complete response rate by incorporating immunotherapy with the FLOT regimen. And the question is which approach to use. As we've highlighted based on the neo-AGES study, they may be similar. We are looking forward to the data from the ongoing Esophageal study, which will compare directly head-to-head FLOT versus cross, and the Top Gear study, which will compare FLOT with radiation versus FLOT with no radiation as a neoadjuvant approach. So I will stop here and happy to take questions.
We actually have a question from the virtual audience. and I apologize if I butcher how to say some of this, but are you testing for PD-L1 CPS in non-met upper GI patients? If you do, does it impact your adjuvant approach?
Yes, so I do PD-L1 CPS in all patients regardless of staging, because if based on the Checkmate 577 study, the subgroup analysis showed that those patients with PD-L1 5 and above has a significant hazard ratio. The patients who have PD-L1 less than 5 actually do not have a significant survival benefit. And so it is the data from Checkmate 577, though very encouraging and promising, we're still waiting for the overall survival data with subgroup analysis looking at PD-L1 scores. But for now, I really limit the use of nivolumab to the patients with PD-L1 5 and above.
Do you have any other questions? No? Thank you so much.
Thank you.